At the moment, we probably have more stories about how providers are experiencing it differently. So we're trying to get those of us, my background is in academic acute care,
Right.
to become more familiar with and better understand other sectors.
Right.
And although we work reasonably closely together, people who work in home care and people who work in acute care hospitals, while we think we understand what each other do, perhaps we don't understand as much as we once believed. So when we bring people together and we basically understand, boy, home care providers have a huge range of service. They're able to handle risk in a way that probably those of us in hospital would be quite uncomfortable with.
Right.
So looking at patients in hospital, I've used this example before, the frail elderly person, she may be at home, she's got some congestive heart failure, some diabetes, some early dementia, she falls and breaks her hip. Sadly, this is all too common a story.
Yes,
When we
yes.
get her into acute care, we want to focus on all the problems. Well, what really brought her in was her broken hip. How about we fix the hip and get her back out and ask, how do we continue to help her manage her chronic disease, be it diabetes or congestive heart failure, and her dementia,
Right.
in a home-like setting?
Right.
So I think that's the risk tolerance in home care is very different. I think the other thing we've learned is the preponderance in acute care, because of the way the bed stock has evolved in Ontario, with it mostly being acute care beds or long-term care beds as opposed to assisted living, more aging at home, more home care, pushing acute care providers back from the concept that once you come in with a bunch of those things, you're definitely going to long-term care, and really changing the culture to say no one is going from acute care to long-term care. Or I should say very few people, perhaps a Maple score of 5, where
Right.
they can do almost nothing for themselves. But if there's a chance we're going to get you home, we're going to take you home and we're going to put significant and intensive resources in place to keep you there. If that doesn't work, we're also finding from our patients, they're much more accepting of leaving their home and going to an alternate level of living when they've given it a shot and discovered it's not actually working for me. So it, I think, has also been beneficial in learning, we tried, here's how long we tried, and here's what we did. And it helps patients, I think, come to terms with the fact that maybe institutional living is a good phase for them next. But it doesn't have to be long-term care. It may well be assisted living or congregate living or significant home care for periods of time.
So we have to open up the range of options?
I think very much so.
Are common and...
Open up the range of options, not perhaps be paternalistic, as paternalistic in saying, oh, you're ready for long-term care. Much more saying, if home isn't right and we should really trial and test that, then where's the next best place to home? As opposed to immediately going to that quite high level of care and very expensive level of care that often those who are the more well patients who've ended up in long-term care don't require, and probably doesn't reinforce the best quality of life. So including experimenting with how we use retirement homes differently.
Right.
I think all of those things should be on the table. Each of them has legislative barriers, risk barriers, media challenges, and all of the political machinations that are
Not to
associated.
mention cultural change.
Huge
acceptance of other options.
Absolutely.
Right.
Yeah, it's a very good point. So when we look at the catchment area we serve, huge issues of cultural influx, new Canadians, very, very broad ethno-cultural backgrounds.
Right.
And I think that's really an excellent point. Our providers have come to terms, or are coming to terms with, what I thought was perhaps the model in my training with a multicultural Canada is quite different, and what new Canadians are willing to accept or see as appropriate is also changing quite dramatically. That having been said, we're also finding with second and third and fourth generation Canadians some assumptions that, for example, in the Italian community historically, where we serve as a very Italian population, people will want to provide more care at home.
Right.
And we're discovering, well, that may be the case, but work-life balance, family demands, a whole bunch of other initiatives are making that perhaps less likely. And far-flung families. In the old days, people didn't move as far away. Now they're living around the globe. So we really are now talking about some other, I think, interpretations or biases we have to let go.